Assalamu alaikum. Good evening. Welcome you all to today's CTO Cathlab manual series to part 2. Today's topic Retrograde PCI. Two of masters of CTO with us, Dr. Kaisar Nasrullah. He is master in Bangladesh. We are also his passion is CTO, relation PCI. And another is, in previous lecture, Dr. Arun Kalyanasundaram. Welcome, Dr. Arun, to be here. He's also another master of CTO. Today's topic is very only designed on the retrograde PCI. At first, topic 1, Dr. Kaisar Nasrullah will talk on angiographic assessment and selection of collaterals, and tools and kits, and guide catheter navigation and guidewire handling. And Dr. Arun will talk on connecting the antegrade and retrograde channel, then retrograde wire crossing technique, externalization, and complications. I think we can touch all the bit of retrograde PCI. Now, requesting Professor Abdul, sir, please opening remarks and start the session.
Good evening, everybody, and assalamu alaikum. Before starting the session, we have an announcement. One of our renowned senior cardiologist, one of our teachers, who started the cardiology service in this country, Professor Amanullah, died this evening around 6 p.m. at his home. Inna lillahi wa inna ilaihi raji'un. Paying homage to one of our great teachers, today we are bearing the torch of education in cardiology. And today we are going to learn about retrograde PCI. I have to confess, I'm going to be a student here because I do not do it. And so today Kaisar and Arun Kalyanasundaram is going to be my teacher, and I'm going to thoroughly enjoy the lecture and perhaps learn to do that on my own. Let us go together and learn.
Sir, exactly, sir. Today we are not faculty. I think we are the participants on the session because two master speaker here. I am requesting Dr. Kaisar Nasrullah, please start your talk. Dr. Kaisar Nasrullah is the senior consultant of University Hospital, Dhaka.
Assalamu alaikum and good evening to all. Mohsin, am I seen and audible?
Yes, sure. You're seen audible.
It's a really great honor to be here to present a talk in front of such a learned gathering. I think the person who will talk after me, he is much more learned. I also learned from him in quite a lot of international seminars, and also from all of you. So I'll try with my small capacity to share my knowledge and experience, which Dr. Mohsin has given me the task. So I have nothing to disclose. Before starting my lecture, I want to pay homage to my teacher, Professor H. Khan Chowdhury, and also just now I heard from Wadud Bhai that Professor Amanullah Chowdhury, who was also director, our president, Bangladesh Cardiology Society, and also Dr. Monowar, Dr. Moin, and many more than 100 doctors who died, especially of COVID, serving people. May Allah bless them, Jannah. Well, gaining knowledge is the first step to wisdom. Sharing it is the first step to humanity. And I would like to salute and also express my heartfelt gratitude to IPDI, especially Professor Wadud Chowdhury and Dr. Mohsin Ahmed. One of them is my elder brother and one is my younger brother, to arrange such a nice platform who motivate juniors for learning and thus serving patients in a better way throughout Bangladesh and also globally. So the topic which has been given to me, topic 1, it has got 3 components. 1, angiographic assessment and selection collateral channel analysis. Agenda 2, tools and kits of retrograde CTO. Agenda 3, guide catheter navigation and Guidewire handling. Let's take one by one. First, before starting the agenda, I just want to share 2 slides with all. The basics of retrograde CTO. So when to consider retrograde? When there is a proximal cap ambiguity, poor distal bed, bifurcation at distal cap, antegrade failure, and of course you have to have good interventional collateral to go retrograde. And this one small picture, if you keep this in your mind, in your thoughts, then CTO becomes easy for you. You have to connect the antegrade and retrograde lumen, either antegradely or retrogradely, either by wire escalation method or dissection and re-entry method. So if you understand this basic picture, your understanding of CTO will be very easy. Keep this in your thoughts. Now let's take my agenda today. Agenda 1. Angiographic assessment and selection collateral channel analysis. Genghis Khan reigned half of the world from 1206 to 1227. His famous quote, he never lost a battle. If you know your enemy and know yourself, you need not to fear the result of 1,000 battles. And in CTO also this rule applies. So you have to perform your angiogram properly, dual injection angiography, drop magnification, no panning, sequential injection, long acquisition, multiple views to illustrate CTO anatomy and collateral. You can see the 2 pictures. The left side, there is the panning, so that you can't understand the CTO properly. On the right side, you fix the your cine, and you can visualize the CTO segment very clearly with its collateral. So characteristics of optimal angiography in CTO PCI start with low magnification with shutter open for initial angiogram. Retrograde injection first, must opacify all collateral. Long run, stay on cine until contrast washout. No panning whatsoever. Ensure prior details review of any previous angiogram, particularly post-CABG patients. Dual angiography is essential. Goal, optimally image the lesion, the distal vessel, the collateral channels. And spend at least 20 minutes with diagnostic angiogram. Discuss with your experienced colleagues. There's no shame, no ego. Optimal projections for RCA CTO, like there are some pictures. For proximal cap, you can take LO 30 view, iliocranial for distal cap or bifurcation. For septal channels, iliocranial or IO 30, whether it's coming from the LED to PDA or PLV. LED CTO, iliocaudal, proximal cap, iliocranial for visualizing distal cap bifurcations, iliocranial, distal cap septal collaterals, and IO 30, especially for septal collaterals coming from RCA PDA or PLV. For optimal projection of SARC CTO, epicaudal, proximal cap, iliocranial for distal cap, ariocaudal, proximal cap, distal cap, and IO 30 septal collaterals to LPDA. So for angiographic assessment, you have to see 4 key points. 1, proximal cap. 2, CTO segment. 3, distal cap. 4, collateral vessels. And we all know these protocols, the American guideline. You have to take dual injection and visualize all these antegrade and retrograde pathways. And you have to see whether the proximal cap is ambiguous or clear. You have to see your distal target, whether it is poor or clear. You have to see the intervention collaterals, whether it's clear or it's ambiguous, or there are some characteristics, and also the lesion length and lesion characteristics, more than 20 millimeter or more. So first you look at proximal cap in angio. Is ambiguous or unambiguous? And you plan your hardwares, types, whether it's blunt or tapered. Tapered are easy to go through, I think, filter XTR wire or XT-wire sliding method. Blunt, you have to puncture the cap. Usually it is hard. Location, presence of proximal tortuosity side branch. With the side branch, you can take an IVUS and see the origin of the proximal cap. So here's an example of proximal cap, which seems ambiguous and blunt. So you need a hardware to penetrate it. And then look at the CTO segment after proximal cap. Its course is tortuous, ambiguous or non-ambiguous, unambiguous. Its length more than 20 millimeter or more. Side branches, calcified, angulation. And also another point which is not written here, sands. Is there in between these two proximal distal cap, there is some island of vessel seen. So you can target at those also. Next, distal cap. Same, ambiguous or unambiguous, distal field quality is poor and involvement of bifurcation. And next is, you can see this is a distal cap, which is a bit of, seen, but if you can take a long scene, you can see that it's going up. And then collateral vessels, you have to see what type of collaterals are there, is characteristics, especially frame by frame. Again, you have to identify your suitable collateral for your retrograde wire crossing. So there are 4 types of collaterals: septal, epicardial, graft, venous grafts, and lima. So you have to plan 1, 2, 3, 4, 5. If I will try this first, if I fail, then I go for second, then third, then fourth. Planning is very important. Next, you have to identify ideal collateral. An ideal collateral is when there is origin and insertion is more than 90 degrees. That means obtuse angle, clear connections, no side branch, no tortuosity, no bifurcation. And you have to assess the collateral course. So if you assess, like for RCA CTO, there are so many collaterals you can see in the pictures, but usually do from LED septal to RPDA, or AV to AV SARC to PLV, or apical LED to RCA PDA. These are the 3 things commonly taken to pass the retrograde wire. Next, to assess for LED CTOs, when you have to come from RCA to LED CTO retrogradely. So what are the likely collaterals? Again, RCA PDA to LED, or RB branch to LED, or RA branch to LED. And of course, from PLED to distal LED. And for SARC CTO, you have to choose diagonal to OM or PLV to AV SARC. And again, second is, we'll focus on septal collaterals. Septal collaterals, you have to see some characteristics to choose your ideal septal collateral, like the connection of the quality of the septal collaterals. It is side branch like, or it is just thread like, or it is almost invisible. So if it is more like side branch, it's easy to cross. Next, exit from dollar vessels. It is obtuse more than 90 degrees. It is easy to cross. If it is acute, or if it is bifurcation or stent into it, it will be difficult to cross. Collateral tortuosity, if there is no acute bend, or only 1 or 2 acute bend, and if it's more than 3 acute bend, which is seen in the third picture, it will be difficult to cross. Again, entry to recipient vessels, the angle is obtuse more than 90 degrees, or it is acute, or it is near to distal cap or not. If it is away from the distal cap, it is easier to cross. And collateral direction, is it LED to PDA, is easier than to RPDA to LED. Now, the next collateral, epicardial, which we use less, because if you perforate epicardial channel, there will be pericardial tamponade. Septals usually benign. So again, epicardial has got some characteristics like its size, its tortuosity, its entry. You have to consider all these things and be very careful to negotiate it, because if it perforates, usually it might cause pericardial tamponade, and then you have to close the both ends of the collateral, not one end. Next is venous graft collaterals. Again, there are certain characteristics like graft patency, anastomotic angle, anastomotic locations. And last but not the least is lima graft. So again, you have to see anastomotic angle, anastomosis location, and tortuosity of lima. Sometimes when you cross lima, it is so sensitive, it causes spasm, and you can't see anything, no dye goes. So you have to keep like diltiazem, channel blocker to dilate those things. So optimal CTO angiography and systematic evaluation is very important. So you have to take dual angiography, you have to evaluate the angiogram, and you have to assess the collateral. It is imperative for retrograde CTO PCI efficiency, safety, and success. Now my second agenda, given by Dr. Mohsin, tools and kit for retrograde CTO. So you all know, when you have to fix a problem in your home, you need all the instruments in your toolbox. Similarly, for CTO intervention, you need a complete CTO toolbox in your cath lab ready for your higher success. So, outline of a CTO toolbox, I divide into 4 headings. 1, to cross the lesion. 2, to dilate the lesion. 3, to support low EF. 4, to combat complication. To cross the lesion, specialty wires, CTO wires. For supporting this wire, microcatheter, ADR devices, which is usually used in antegrade CTOs, not for retrograde, intravascular imaging. B, to dilate lesion, we need specialty balloon, Guide-Fxtension and trapper balloon, and sometimes when wire cross balloon does not pass, rotablation. To support low EF, hemodynamic support, sometimes impeller. To combat complication, perforation kit. Now, to close the lesion, we need specialty wire, microcatheter, and IVAS for retrograde CTO. Specialty wire for microchannel tracking filter XTR, gap penetration, Gaia series, Pilot 200, Confluenza Pro, knuckle dissection, you need a slippery wire like Pilot 100, 200 filter XT, dissection reentry, Stingray, retrograde crossing, Sion, Suo 3 for very tortuous septal channels or epicardial channels, filter XTR wire, and sometimes Sion black. For externalization, RG3, R350. So this is polymer jacketed wire Pilot or filter XT wires. Higher penetration force wires, Asahi Gaia series. Now Gaia next has come, though it's not allowed outside Japan till now. And next, there are Confluenza Pro wire for penetration, for piercing the hard cap. You can use wire also. And for very hard cap, you can use like Confluenza Pro 820 or Astator XS20, XS40. For knuckle dissections, you can use filter XT wire or Pilot. And retrograde wire crossing, I've said Asahi Sion, Suo 3 or filter XTR wires. For externalization, Asahi RG3 or R350 Guidewire, long wires. And you need this instrument also snare. When sometimes you cross the retrograde wire, you can't get it into the antegrade guide catheter. You need a snare to catch the retrograde wire and pull it into your antegrade guide catheter. Microcatheter, different spectrums, fine cross turnpike, Corsair turnpike, turnpike spiral, Mamba, turnpike gold. And you can see this is a Corsair Pro microcatheter from Asahi, which used as a also for support and also for as a channel dilator. There's a series of turnpike catheters. Turnpike gold is used for calcified lesion. LP is flexible lesion, the tortuous lesions. Mamba from Boston and Caravel from Asahi. And this is the twin pus or teleflex catheter, which is to double lumen when you want to take 2 wires. And Sasuke from Asahi. And another very important instrument is IVUS, especially in retrograde approach. You have to see the size of the balloon during reverse cut, and also sometimes when you can't connect the retrograde and antegrade wire to know the position of the retrograde wire, you can use IVUS over the antegrade wire for retrograde approach. So this is the zigzag puzzle of retrograde wiring. So U2 wire, antegrade and retrograde wire can be in the same plane, like in the plug or true lumen, or both could be in the subintimal space. So if this is the position, both were in the same plane, either subintimal or in the situ lumen or intraplug, then it will be very easy to connect these 2 wires just by increasing the size of the balloon. Sometimes if the antegrade wire is in the true lumen, but retrograde is in the false lumen, if you use bigger balloon, you can connect the both wires. But if the retrograde wire is in the true lumen and antegrade wire is in the subintimal space, it is very difficult to connect. At that time, if you find this through IVUS, you have to pull out the retrograde wire and redirect it into subintimal space, and then use a bigger balloon to connect these 2 wires. To dilate lesion, you need a specialty balloon to support. Sometimes for the balloon to cross the CTO, you need Guide-Fxtension, and sometimes trapper balloon to exchange the balloon and hardwares. And rarely, when you pass the wire but can't cross anything for calcified lesion, you have to use rotablation as well. So specialty balloon, there are different types of balloon, like Sprinter Legend, like Tazuna, and you can use for calcified lesion Flexstrom, chocolate balloon, or Wolf Rhine. And Guide-Fxtension trapper balloon for support Godzilla from Boston. And then trapper balloon, this is a special balloon with which you can easily exchange the hard wires, CTO wires. And atherectomy demise, there are lasers, rotational atherectomy. And next, to support the low EF, you have to give hemodynamic support either by impeller or percutaneous heart pump. And never forget, you have to have in your toolkit box to combat complication. I can assure you, if you do CTO, one day it will happen. And if you are not prepared, patient will die. So you need to have perforation kit like this pericardiocentricity trolley, and also cover stent like Graftmaster Papyrus, or coils for occluding the small septal or epicardial channels. And you need to have the microcatheter to deliver those things. At that time, if it doesn't match with microcatheter you're using, then the coils will not go. So build cards to improve efficiency. One card for perforation card, one is CTO card. Now my next agenda, agenda 3, and my last agenda. Guide catheter navigation and Guidewire handling. So you have to build up a system. You have to puncture double. Approach sites could be femoral, radial, brachial. You have to choose the catheter size shape. You have to choose the wire supporting device. Approach could be femoral, femoradial, or radial. And guide catheter navigation or guide catheter type, you have to use backup type of guide catheter, which give strong support, especially for left XB, for RCA like L1, hockey stick, or L.75, and take a bigger lumen catheter like 7 French, 8 French, and sometimes keep a side hole in the catheter or make a hole to keep enough coronary flow. You have to work long hours And of course, remember, when you're doing retrograde, you need short guide catheter. In our country, it's not available, 90 centimeter catheter. So you have to cut it and make a short guide catheter by using the lower French cordis sheet. So 5 categories of CTO wires: proving invisible intraplug channels. If you think there could be channel tapered tip of the proximal cap, you can use polymer jacket tapered software like Filter XTR or Filter XT or Pilot 50 even. Retrograde collateral wire, usually non-tapered hydrophilic low ground force wire like Sion Black, SO3. Lesion crossing, wiring in complex lesions, non-tapered medium ground force like Pilot 200. Penetrate hard lesion, very hard distal cap or proximal cap, Confluentia Pro 912, sometimes 820. And CTO intraplug navigation. If you know the direction of the CTO, then use Gaia second, Gaia third. Gaia next is coming. And shaping of the wire, the right shaping for the CTO wires is only these two. So give a small bend if you want to puncture the wire, which is F, and give 2 bend. One bend 1 to 2 millimeter away from the tip, another bend 3 to 4 millimeter away from the tip. So one is around 50 to 30 degree, another is almost 60 degree. And wire manipulation, do it with art and also science. So finger motion, rotation, pull and push, and there is some drilling method, penetration method, sliding method, or push and deflect method. I will show one by one. So while drilling method, you have to use hydrophobic wires which give a good tactile feelings like Miracle series. Sliding means, when you slide through a small micro channel filter XTR wire, XT wires, puncture hard cap like Confluentia Pro 9 or 12. Push, deflect, torque when you know the course of CTO Gaia series. Surfing, Sion Black, Sion, sometimes Pilot 50. Knuckling, 70 plus space filter XT Pilot 200. This is, you can see the drilling method. You're drilling through the CTO lesions, drilling with torquer. So this is an example of a drilling method. You can see RC CTO tapered proximal cap, no angulation, calcium, more than 20 millimeter. And here with the support of macro catheter with ultimate bros, which is a very good wire. You can see you drill through the CTO lesion. It is like Miracle 3 or 6. Sliding method, you just slide through the micro channel. So here is the angular lesion. A small micro channel is seen in the OM origin. So tried with BMW wire, but it's stuck when sliding by whisper wire, slippery wire. On the CTO, you use filter XTR wire. You just slide inside it, and you can see just sliding in and going down. Puncture with torquer. When you can see the tip of the wire, it is just one bend, 2 millimeter from the tip, almost 45 degree. So you can use it with a harder wire like Conquest Pro 9 or 12. But you have to know the direction of your wire because it can easily perforate the artery as well. And this is, you can see push, deflect, and torque. You push the wire. If wire is going in the wrong direction, it will deflect. Then you just deflect the wire, just rotate and change its direction, and then again torque. This we use for Gaia series. So there's an example, the CTO and LED post-cabbage patient. So you can see it's a Gaia wire, Gaia second. So we push it, the tip is deflecting. You can see tip is bending. Then we deflect and torque the tip and then guide it to the right directions. And you can see easily the Gaia is going forward and crossing the CTO lesions. To confirm it's in true lumen by orthogonal injections that it has gone to true lumen distally. And usually bend used for septal. When you go into the septal, you have to give a acute bend, long bend, But when you, for septal crossing, then you have to give a small bend. And usually, if there's a visible connection, use Sion. If extremely tortuous, then SO3. If invisible, then filter FC or XTR wire. Basics of negotiating collateral: take proper view, take software, be very gentle to negotiate collateral channel, use always support catheter. So take home message, 10 commandments: no ad hoc PCI, CTO PCI at least, dual injection, study angiogram, make a plan, check ACT every 30 minutes. I put this task on my sisters. They do it because I can't remember those things. And if you miss, there will be thrombosis and disaster. Support like microcatheter, ECG and pressure monitoring. Sometimes there could be VT or ventriculectomies when where in the false lumen or outside intima, outside the vessel wall. Minimize radiation, vigilance for complications, and be ready. And of course, the last word, persistence. So take home message: retrograde approach has the potential to be the last reliable method to recognize CTO. Battle against CTO can't be won on the day of procedure, rather day before the procedure. So planning from imaging, strategy and technique, appropriate hardware and device is very important. There is no shame in referring difficult and or failed cases to expert operator or cabbage. You've got a very good colleague, surgical colleague. Sometimes it's better to lose your ego to win patient's heart. So this is my team, and this is one of my mentors from Japan, Satoru Sumutsuju. I am indebted to him because I learned all the techniques from him in my initial days. So be grateful to your seniors who taught you. And it's my last slide, which I always show: keywords for success of CTO. So you're in a long queue to pee. And of course, you're the last person in the queue, the intervention cardiologist. So reach to the toilet, you have to have patience. And you're climbing a up mountain, and to reach at the top, you need to have perseverance. So patience and perseverance are the keywords for success of CTO. Thank you, sir, for your patience hearing.
Thank you, Dr. Kaisar Nasrullah Khan. Excellent talk. I think precise talk for the for beginners or learners. I really grateful because it enrich our Hello YouTube channel, because everybody learn from your talk. Thank you, Dr. Kaisar Nasrullah Khan. Dr. Arun is waiting for the next lecture. After finishing Dr. Arun lecture, we can discuss.
Sure.
Yeah, sure. Dr. I just little brief just introduction for Dr. Arun. Dr. Arun is an eminent interventional cardiologist, the leading in hospital globally. Now he's working in Chief Division of Cardiology, Promed Hospital, Chennai. He's a global proctor. He also worked in lots of complex cardiac intervention and CTO, mentor, proctors of the different institution. He now also director of Fortis Hospital, New Delhi, Indian top cardiac center. Dr. Arun, please start your talk.
First of all, really again, greatly appreciate having the opportunity to be here and amongst friends in these difficult times. Hopefully next year we will meet everyone in person. I do have to completely agree, Dr. Khan, that was a fantastic lecture. So I'm going to try and minimize the overlap and fill in the gaps. I would really like the people that are watching and those that are participating to ask questions, make it interactive. This shouldn't become a monologue. Retrograde CTO PCI is kind of like the last frontier. So, I mean, I'm going to try and show you guys some of these things, but the key is like, once we do this, let's actually have a good conversation. So I think Dr. Khan has pretty much told you when we typically go retrograde. So I don't want to belabor the point. But many times, one of the key things is if you have a usable class, collateral and you can get it antegrade, I mean, really your choice is you got to go retrograde, right? So this is courtesy my friend Craig Thompson. But in essence, right, you got to go, since you can't attack from the front, you got to attack from the back. And for that, you have to have a conduit. And they fall into the category of bypass grafts, septal collaterals, or epicardial collaterals. And now that you have control distal to the CTO segment, you still got to connect the planes. Now that's where you got the two options essentially, which is retrograde wire escalation. And for today's day and age, you have some variant of reverse card. There are times when you still have to go old school and do classic card. And once you've done that, typically you externalize the wire. If you don't do that, you might want to convert to an antegrade system, finish your PCI, and then you got to get all the gear out safely, right? So again, basics, I think this has been touched upon. Many times when an angiogram has been done by a CTO person or if it's been done by a non-CTO person. For starters, large views, no panning, make sure you get the right views to look at the collaterals. There's been an extensive discussion on the wires, so I'm going to just skip this part. But the good part is that, I would tell you that you have to be facile and you got to be a good wiring guy before you start doing retrogrades. Now, we didn't typically talk about surfing versus not. For surfing, my go-to wires really are first three, I would say. But it used to be Fielder FC. In fact, before Fielder FC, it was Pilot 50. And then now you have Fielder FC, and in fact, it's moved on. Now you got Cyan Black from Asahi and Samurai RC from Boston. I don't typically surf with XDR. I pick one of the other two because Cyan Black or FC has a higher chance of picking up an invisible collateral. And when you have like wicked tortuous stuff, I usually go back to Cyan or SU03. We've talked about microcatheters extensively. So the key is you got to know, make sure as you start doing retrogrades that your tech by mistake doesn't hand over a short 135 microcatheter. And, when you want to go retrograde, you got to know how long are the various catheters, and what you typically need for various things. So I'm going to kind of show you a quick case. This was actually a case from 2 years ago when we were still traveling. So this was a live case that I did in 2019 in Hong Kong. And this was kind of the case that I got. So I'm just going to let it play for a minute. So it's an RCA CTO, not a super challenging collateral, but a lot of calcium, and it's about, I don't know, maybe 100 millimeters long. So that's kind of what we're dealing with. And you can already see here, there's a lot of calcium out there. And so the first thing, right, once you've seen the angiogram, you got to have a plan. So this is what was going on in my mind. It's a long segment. It's kind of an unambiguous cap. It's only been tried and failed by an expert before. There's calcium I got to deal with, and the distal caps at a bifurcation. So in my mind, I probably cannot wire this antegrade. I know that, right? I don't think it's very feasible or efficient. So I'm already thinking, all right, I got to go retrograde in this case. I got to, and it's long enough. If I can't wire it antegrade, I probably can wire retrograde. So I'm going to plan to do reverse card. And if that doesn't work, what's my second option is to probably do some kind of a high in ADR because it's at a bifurcation. So first thing, you got to prep the antegrade bed. So again, this is the theme is that many times, even if you're going to go retrograde, there are exceptions to the rule, but typically, again, for starters, I would say typically start antegrade, because if you win, you're done. In this case, I knew my chance of winning is low, but I know I have to prep the antegrade bed. So good guide, it's an Amplatz 1, microcatheter. I'm not even trying to wire it. So I got to be efficient. I'm on camera. So I started knuckling, right? And I tried, I thought, well, I'm going to give it a shot. I'm going to put in a Guide-Fxtension catheter and let me see if I can get anything out. So you can see that even trying to get a microcatheter across the calcific spot, it's just kicking the guide out. Again, just an illustrative example of why the usual techniques of increasing backup, different microcatheters didn't really work. So what did I do? So you got to, and again, this is like 2 years ago. We don't have laser and all this good stuff. So my option is I take the microcatheter, that's a Corsair, as far as it goes. And then I just said, all right, I gotta do something different. So I just managed to torque it as far as it would go, took out the wire, put in a rotor wire, and in fact it was a shortened rotor wire. So I cut the tip, put it as far as it goes. That's a 1.5 burr, which I knew I'm actually drilling into the subintimal space. The key is you got to prep it, right? So once this is done, now watch it. I don't have a Guide-Fxtension catheter, nothing. This is just the same microcatheter coming down over the rotor wire. And actually say, I'm sorry about the length of the fluoro, but you will see it come towards the end. Hold on. Boom. A rotor wire, once it's done, the microcatheter just slip right in, right? Easy. So once this is done, I now have a knuckle. It's okay, antegrade, and it's probably an XT that I had. Now I take out the microcatheter, balloon, get my Guide-Fxtension catheter, and I'm all prepped. Antegrade, I'm done. So the next step is I got to come and attack it from the rear. So crossing the collateral, this is just a regular Cian, crossed it without much effort. That's a septal, it's pretty safe. It's a great starter collateral, but now is the next problem, distal capsule bifurcation. And you don't want to lose any of the branches, right? The PDA, and this is PL. So the next thing was penetrate, and then I had a retro knuckle and an antegrade knuckle. Now I'm in the game. It's actually pretty easy after this. So retrograde knuckle, antegrade knuckle, and just to show you, right, about semantics. How do you connect these planes? That's one of the topics that I have to address today. So once you're across, right, what you're doing essentially is creating a space with your antegrade balloon and entering the same space with a retrograde wire, which is over a microcatheter. And that is reverse card. I mean, you have contemporary reverse card, extended reverse card, guideline reverse card, whatnot, but they're all the theme is the same. You open up a space and enter the space with a retrograde wire. Why didn't we just call it card? Why do we call it reverse card? Because the technique was pioneered by the Japanese even before all these microcatheter advances. So before, what we used to do is take a balloon, go retrograde, open up the space, and then get into the same space with an antegrade wire. This was card. And because this was card, the opposite is reverse card. What is Guide-Fxtension reverse card? You're just making it a little bit easy. You're taking a Guide-Fxtension reverse card and entering the Guide-Fxtension catheter. It helps with antegrade support, bridges the gap. You don't have to shorten the guides many times. Reentry is easier. I got a safe zone. You don't have to do stent. I don't remember the last time I had to do a stent reverse card, probably like 3 or 4 years ago. So it actually makes it a lot like idiot proof. So I tend to do that a lot. So Guide-Fxtension catheter and now retrograde wire, just advance that into the antegrade guide. So typically what you do is, and again, this is actually courtesy James Pratt. I think I did thank him for that. I mean, we've all done this. That's actually a turnpike catheter, which we don't have in Asia yet. I mean, at least in South Asia yet. So as you can see, what you do is have it all set up, advance the wire, load the wire over this way. And now you have a wire going in like this, all the way through the heart, back here and out here, right? And then we still did an imaging to optimize the result. And that's the final result, post rota, reverse card, blah, blah, blah. And in fact, honestly, it took like about 2.5 hours, I think, if I remember right. And so we were able to do it within like screen time. So, you know, again, I'm going to just show you a couple of things just to belabor the point and to show you a few of the techniques of making antegrade retrograde connections. So here, ambiguous cap, distal caps are a bifurcation. It's a circ, and I don't have a septal. But in fact, there was nothing to do antegrade, and another person had already tried antegrade and failed. So I tried So my plan was I'm going to see if I can get an IVS catheter. Didn't work. Antegrade wire escalation if I can do step 1. So 1 and 2 are, 2 and 3 are contingent on doing 1. Otherwise, you got to go straight to 4. So then I ended up going straight to 4 because I could not, for the life of it, get any gear into the proximal cap. So in fact, I had to use a dual lumen catheter to even get into the epicardial, right? And so this was even just getting in. It's a bad angle of entry. And then this is just to show you how tortuous the epicardial itself is. It's like, all those dark spots you see are essentially 360-degree loops. But this is the wire that Dr. Khan just talked about. SU03 has changed the game. So, honestly, I don't know if I could have wired this with Xeon. So, I didn't even try. I just went straight to SU03, knowing it's safe and a caravel, and I managed to cross it. So once I was here, now comes the next problem. There's an angle of exit issue. So it's super challenging for me to do reverse card if I'm not able to do, get stuff in. So what do you do in these solutions? So this is another way you can manage, these challenging situations. So in fact, what I did was I did a retrograde Carlino, where I intentionally dissected the vessel into the circ. And I want you to pay attention here, actually, and this is still an ambiguous course. As I was doing this, I had a wire just to ensure that the Carlino doesn't go all the way into the left main, and even if it did, I have a safety wire. So now you see that I got a wire, so I'm in control at this point. So this looks ugly, right? Most of us would be like, what the hell are we doing here? So Carlino done, and so then I managed to get it into the branch. And then basically what I did was this technique called kissing wire. So I got a retrograde wire, and then because of the Carlino, I was able to get antegrade wire down. All right. And then I got it into the obtuse marginal using the retrograde wire as a target. And then this is just to show you that I'm in the true lumen. How do I know that? I didn't take a picture. That's just a workhorse wire, and I'm in, right? And then I put in a dual lumen catheter, which I had initially used to try to get here. I used the same dual lumen catheter to get into the epicardial, and there, boom, we are in. Now exchange again for workhorse wire, because now, we are in the game. This is game over at this point. So done, PCI, blah, 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 and that's the final result. All those ugly Carlino stuff is all healed. This is the same thing, and that's the collateral. This one, lower one, is the one that we took. So you got to also know, right? What do you do? This is some of the stuff that I was asked to talk about. You got to learn. The very first thing is learn how to use different microcatheters. How do you use Corsair? As the fingers show, that's counterclockwise, turnpike, better clockwise. Fine cross and caravel are typically push catheters. This is, again, you got to know how to do these things. A couple of other things. If your 150 Corsair or turnpike doesn't go, you could take a shorter microcatheter because the torque transmissibility is better. Or once we get XS and LP, we can use those, right? You can enhance pull. I almost do this. If I get a wire in, I trap the wire. If it's a septal, you can balloon it. You never, ever, ever balloon an epicardial. And obviously the basics, you got to enhance support. This is a case from actually China about 4 years ago, where I am radial femoral. You can see Guide-Fxtension catheter, all this stuff. I can't, so I'm here till this point, I'm there. And then the wire is going haywire. I don't know where to go. And my antegrade wire is coming down here. So this doesn't feel right at all. You see the retrograde thing here. So this is the RCA that we're dealing with, right? Knuckle. So then I had to use a retrograde Carlino again. So that's the tortuous collateral that I had to deal with. So once I was here, I was super confident. So then I was able to wire down here, get my microcatheter over the knuckle. See there, boom, boom, boom. Guide, wire, knuckle, microcatheter. Now we are good. Guide extension catheter, balloon, reverse card. same concept. Retrograde wire into the antegrade Guide-Fxtension catheter. That's the final result. Straightened out a little bit, but you can appreciate the tortuosity in the RCA. There was a mention made about snaring. This actually was the same day I did the other case. So this was another case. This is actually the last case of the day, where you can see super calcific RCA, and this is a true osteal RCA. These are bad because there's only one way to do this. So I was able to get all the way till here, retrograde, and now comes the problem. I had to go retrograde through to true. I did it with an Astato, I think 820 or something. Anyway, this was done. So there you can see it. So you got to puncture, check in multiple views, make sure you're not puncturing into the pulmonary artery, blah, blah, blah. All these, I mean, you got to confirm that you got to, this is a field thing. You got to make sure you are in the aorta and you're free and you're not dissecting into the vessel wall of the aorta, because that's bad. So this is done, microcatheter in, and now you never, okay, another rule for snaring. We talked about this briefly, but we danced around it. You never snare a short wire. That's an RG3. And then they told me that there was no snare. So you need to learn how to make a snare. And so we just did a homemade snare. Essentially, it's a balloon and another wire that I just made into a snare, then cut it. And then what you do is once you've snared it, life gets a lot easier. In fact, I ended up snaring it here. You'll see it now. Boom, snare, boom, 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 boom. There it goes, right? So once it's done, you got to make sure you don't lose all the stuff. Get your, essentially get it down. And I mean, the rest is not particularly hard. You see the guide, now you're good, right? I mean, the rest is just PCI. So we have talked about SU03 and all these wires. So just about SU03, couple of things. For those that are not familiar, don't do the surfing. This is a finesse wire. Don't torque more than the heart rate. Make sure you move your microcatheter, go back and forth, be gentle. The Western operators, we are many times blamed of being very aggressive, but this is the one time where, with CTO PCI, I mean, Dr. Khan talked about patience and perseverance. I would say the other thing is there are times when you have to be efficient and move fast. There are times when you have to be patient. And I think, you really learn and you're good at CTOs, or, you need to know when to do these various things. And the fourth thing, stop when you have to. I think he worded it very nicely. You win the heart. It's okay. Everybody stops and everybody fails. It's all good. So in essence, we have talked about this, but SU03 can pretty much do a lot of the stuff. And septals, I still go with one of the other wires that give me more body, like a Cyan or Cyan Black. We have talked about all this. Now, reverse card, I've already kind of told you what it is, so I'm going to skip all this. In the interest of time, I'm not going to get into the details of the various types of reverse card. And again, we can kind of save this for another day. But in essence, you got this extended blah, blah, blah. You got to know what happens when you can't re-enter. This is a troubled thing that you can often get into, right? Why might this be difficult? Because antegrade and retrograde system are not in the same space. That's the number one reason. You're not able to connect, although you're in the same space. You've re-entered, but you don't realize that you've re-entered, and then you go back into the subintimal space with your retrograde wire. The case that I showed you, a flush osteal occlusion. When you have bifurcations and the wire goes into a branch, or you're going into a graft, you often see this. You cross it, and then the retrograde wire goes into the graft. And sometimes someone has stented and done a bad job, and it makes it even harder. So what do you do? Many, 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 many times. The answer is always dilate on the antegrade wire, right? Because anytime in these four situations, when they are in four different, the four permutations, right? Typically dilating works. So go with the bigger balloon. That's like the easiest thing that I would tell people. So if it's too far, and this is from my good friend Stefan, I'm not savvy enough to make these cool cartoons. So if you take an iris-like view, that's a really nice animation that I thanked him for, and I can use it, balloon it, and then use a hardwire to connect the dots. Larger balloon makes it really easy because the spaces are connected. Go at the area where the wires are the closest because it's easy, right? So you don't want to go when it's super far. And again, bigger balloon, go for the closest part, use a harder wire. What do you do for when you've re-entered but still gone back into the subintimal space? Guide extension over SCART makes it easy. Like I said, this should be your default if you can. Other solutions are, you can, like I've already showed you Carlino, you could do IVIS to understand where these things are. You can always knuckle both ways, which I tend to do quite a bit. And also sometimes I've had to do this where essentially you have a stent and ISR there where you just can't connect it. If all else fails, crush it. But make sure you do a good job of the new stent. And if that doesn't work, go ADR. And this is a case where, again, from a couple of years ago, where I just couldn't do reverse card for whatever reason. I knuckled, blah, blah, blah. And then I ended up just using my retrograde stuff as you can see, that's a retrograde microcatheter. I tried quite a bit. And then I ended up having this balloon and putting in a stingray. This is called a facilitated cart, or I like to call it a facilitated ADR. So that's kind of what I did. And I got the vessel, but I kind of used my retrograde balloon to do this. Now, again, I'm just going to tell you, don't get dogmatic on, this is just to illustrate, move your base of operations. If you have the luxury to, you can connect a lot easier. So that's kind of like a basic thing. You have to learn how to use IVIS. You need to know what's subintima, what's true lumen, all right? So interest of time, I'm not going to go into all this, but you really should know imaging before you do CTOs. So for this stuff, right, IVIS, large balloon, helpful, IVIS might be needed. Be wary of patients who have had bypass. The SVG anastomotic site might be really bad. Calcium is bad. High penetration force, knuckle contrast. We already talked about that. Okay, this was in a case from recent where I just couldn't get my retrograde microcatheter in. So this is another technique that you need to know. When you can't connect the dots, is tip in. Get your retrograde wire into an antegrade microcatheter and bring a antegrade microcatheter. Here, again, this case actually showed I ran a lot of trouble, but there were solutions. Microcatheter couldn't advance. I tried different microcatheters, a shorter one, nothing worked. So then this is from another case, but essentially I tried external cap crush to just modify this area so that the retrograde stuff would go. And even with an external cap crush, where you do is enter the subintimal, crush it. If it still doesn't work, and I mean, this was from that second case where it worked, but as you can see, I'm trying to knuckle in, crush it. I still can't move the microcatheters. So then what do? Don't get stuck. So use my retrograde wire, and then I just made the whole thing ADR. So now I just brought my stuff easy peasy, right? I mean, now you get your, the 2 dots there, the stingray balloon. So this is like from 2 months ago. Got it. And then this is just stingray. So don't get dogmatic. Although I'd crossed super tortuous epicardial, you see the ping pong guides and all that. Don't get dogmatic on, I'm going to do this retrograde. If it doesn't work, switch to antegrade. It's okay. And that's let me just show you the final results here. And I think that brings me to the end of my talk, essentially. So ADR, using my retrograde wire as a marker, there, it's done. The rest is pretty straightforward. So the key is, what am I saying, if I'm saying anything at all, is have a game plan. Always go in prepared. So going back to the first one, never do ad hoc CTO PCI. Failing to plan is planning to fail. And don't get dogmatic on how you're going to approach it. Always be ready to switch to another strategy. Thank you for your attention, and feel free to ask any questions. Thank you, guys.
Thank you, sir. Thank you, sir. The excellent tutorial-based discussion. Thank you. Professor Abdul Wadud, sir, please, sir. Professor Wadud, sir.
Thank you, Arun, and thank you, Kaisar. Both has been very good and in detail. Particularly Kaisar, for the newcomers, your lecture will be very helpful. Arun, I think what you have shown Actually, for complex case like when we are doing the retrograde, whatever teaching we are giving is not going to work unless you start doing it. And
Yep.
what if at first hand somebody is doing it and explaining you why they are taking particular decision. But seeing this tutorial again and again will help the youngsters to prepare mentally how to plan for a retrograde PCI. Thank you again.
Thank you, sir.
Professor Sadir Rahman, Professor Dr. Sadir Rahman.
Oh,
Yeah.
what can I say? I think you're hearing me.
Yes. We are
Yep, we
hearing.
do.
Yeah, because this retrograde CTO approach, yeah, it's sometimes goes beyond even my antenna to understand sometimes, and lots of things are here. The most importantly, actually, what can I say to the fellows that that even Dr. Arun and Dr. Kaisar will admit it, that first we have to be very much familiar with the antegrade approach, because that is the beginning and that is the last end of the CTO for successful CTO PCI. And I think Dr. Arun is now this is very much excel in ADR, because I'm very much concerned with ADR, because that one is the future of CTO in most of the cases, because lots of newer things like Stingray, Crossboss, these things are helping to make even the integrate approach much more successful rather than go for the retrograde approach. But even in retrograde approach, you need the retrograde ADR or something. So two things is very much important. Even I love that one, the knuckling, how to know the knuckling of the wire, and also go to the extra plug. Nowadays the ARC CTO is telling not to just rather to mention extra plaque and interplaque rather than subintimal or subadventitial even. So extra plaque and coming to the intraplaque, this is also one of the thing that which we should be very much familiar, and we know that this one will help going into the intraplaque and the true lumen in the long run. So that's all. Everybody, both of them has just got a very juicy discussion, a bit harder, but it's juicy. Thank you very much.
Thank you. I have a question to Dr. Kaisar Sulakan. For the beginners, when you do the start the CTO, we regularly doing the anti-gate PCI, but we want to start the retrograde PCI in our labs, because you know about 50 to 60% chance of failure by the anti-gate PCI. We should switch to the retrograde PCI. For preparing the cath labs, your lecture is extra lecture for the juniors, but you first mind set up and become confident which channel is more used. The how the fellows decide which channel is important to success of the retrograde PCI. How you usually decide the fellows? Which channel
Thank
is
you,
more
Mohsin. That's a
yeah.
wonderful question for the fellows. Really appreciate. Um, well, you know, retrograde PCA is the last frontier of intervention. Is the hardest part. You all know. It needs time. It needs expertise. It needs hardwares. So you have to plan. You have to take when you fail antegrade, you have to try retrograde, and maybe you might fail in first or two or three cases. Then gradually you succeed. And particularly answering your question, out of the four collaterals, septal, epicardial, or venous graft or lima collaterals, if it's post-cabin patient, otherwise other two grafts are not important. Among the septal and epicardial, you must choose as a beginner septal channels, because if you perforate, usually it does not create pericardal tamponade. It is contained in the myocardium. Secondly, when you select the septal channels, you'll see which is favorable septal channels. That means the origin of the septal channel from the donor artery is more than 90 degree. The entry to the recipient artery is more than 90 degree. That is obtuse angle. Second, connection is very clear, usually not having any branches, and there is no tortuosity, but less tortuosity. These are the septals which you should select at first. Thank you.
Another thing, most important part is the guide catheter selection for the successful of the PCI, especially CTO PCI. Usually, if not guide catheter, support is more so much. So you should, what is the common catheter used in the right RCA catheter in the RCA, you commonly use the cathlabs, right coronary artery CTO. Which catheter you use in for guide catheter support?
Yeah. Again, thanks, Mohsin, for your nice questions. Yes, for CTO PCI, you have to have very good backup support. So always take some guide catheter which is giving good backup support, and also a bit of bigger French. So maybe for left, you take XB, which gave good backup from the arterial wall, aorta wall, and for right, AL1 or AL.75. This is my choice of catheter. Sometimes hockey stick as well. And French, I always prefer for CTO 7 French, but sometimes I took rarely 8 French as well. And sometimes before taking the guide catheter, you also take long sheet. Our Cordish sheet is usually, we take shorter sheet, but we'll take like 70 centimeter or 60 centimeter sheet, which goes up to the, subclavian artery, the Cordish sheet. So it gives good support. And if necessary, you make a hole in the guide catheter, though dye will go more, but it will not damp the pressure because of the larger size of the French or guide catheter. So bigger size guide catheter and having good support, these are necessary for giving good backup support while crossing a CTO. Thank you.
Thank you, Kaisar. Another question, for microcatheter is must for situation. All the operators should use the microcatheter. Even in simple case, you should use the practice for the microcatheter. Which microcatheter is available in Bangladesh for the fellows? Dr. Arun also showed how manipulate the microcatheter. With some tips and tricks from the Kaisar can use the microcatheter. Yes.
Well, I'm not an expert like Arun, so I will tell with my small capacities. That is, usually in CTO, you must take the support of microcatheter. It's a must. It's necessary for two reasons. One is, if the wire is in microcatheter, your wire torquing ability will be increased. And secondly, if you fail with one wire, if you changed into the next wire, like you are trying Gaia 2, now you can want to upgrade Gaia 3, it's very easy to change the wire. But if you're not with the microcatheter in, it will be difficult. In Bangladesh, we have Fine Cross from Teremo and also Caravel from Ashai. These two microcatheter are available in Bangladesh. And one good news I want to give you today, not about CTO, IVL balloon is also going to be available in Bangladesh. They have for calcification. That's a good news.
Thank you.
Dr. Mohsin.
Yes.
I have some different, a little bit different opinion here. I don't know whether Dr. Arun will admit with me or not. That for all CTOs, what you are telling, that for all CTOs, you need a microcatheter, even in an antegrade approach or retrograde, whatever it is. If you mean in that way, so sometimes it's not necessary that all the time you need a microcatheter. Like if the CTO is near osteo, then I don't feel that the use of microcatheter is that much important here. And very fortunately that one of my retrospective study has been accepted this time in Europecia, and where I have made the conclusion that the slender PCI with a 5 French catheter, the CTO is possible, even with miniaturizing and lesser use of the armors like microcatheter even. Like what I say that even my 3 or 400 cases I have done with a smaller balloon support. Microcatheter has got some unique, different, helpful things for CTO, which Dr. Kaisar has told that if you want to exchange the wire, that's okay. That for that reason you need a microcatheter, because that one will help you. You don't need to go again and again with another wire and wire it again. But if it is near hostel, if it's not that much distally, in that case, even a smaller balloon, 1.255 balloon, I'm telling it for the fellows because sometimes they feel that I don't have macrocatheter, or sometimes they feel like that because to withdraw the macrocatheter from the wire, if you don't have a dock extension catheter, then you have to go for the inflator, balloon inflator to pull out the macrocatheter when you have wired already, you have been successful in wiring. And that one, whenever you are not taking a new macrocatheter, that macrocatheter and the wire become sometimes stuck with each other. So with that balloon technique may not apply and the wire will come out. And these are the headaches sometimes that which makes people, the fellows, to start with the CTO that this is a big headache that we are not going to go for it. Okay, so 1.255 balloon, it's also because it's has a delivery system, so it stabilizes the wire and you can torque easily well with these things. I can tell you. I can tell you from my experience also. So that is one thing. And another thing, my question is to Dr. Kaisar is that all a bigger catheter is all the time for retrograde or antegrade CTO. Uh, uh, a little bit, I am just not all the time, because the important thing is that the support, isn't it? That support is the most important thing. So the support, if you can make by an active support, then in that case 7 or 8 French guide catheter, because I'm really afraid of 7 or 8 French guide catheter, whatever the sidewall you will take, because in the ostium, aorto-ostial connections, these are, how the manipulation of the catheter more and more, then it causes sometimes big trouble. So I don't know. This is one of my reservation also.
Dr. Arun, thank you, Dr.
I
Arun.
don't know.
Tell me, Dr. Arun.
Can I add something?
Yeah.
Regarding
Yes,
the
sure.
microcatheter, what Sadhur said, I do agree with him. And I did first integrate CTO in 2005. At that time, microcatheter was not there in Bangladesh. And we have seen in some seminars that they are using foreigners, a microcatheter, like those things, but those were not available at that time. And I went with, at that time, this type of CTO wires were also not available. So I did that one, as a 1-year-old CTO in a young guy, single vessel, with just a Galileo intermediate wire. So as I don't have microcatheter, we at that time, most of the operator used to use balloon support. So I took a PTCA balloon, and with that balloon support, I crossed the lesion and succeeded. So when microcatheter was not there, balloon support was a good means, and microcatheter has increased the success of CTO a lot. Earlier, it was failure rate was 50-50. Now it is more than 80 success rate.
Thank you.
And regarding the larger catheter, it depends on the operator who are comfortable with what size of catheter. I use usually 6 French, maximum 7 French.
Thank you. Dr. Arun, do you hear me?
Yeah, I'm with you guys. Yeah. So
Just I have a question to you. You use the radial or femoral in CTO PCI? Usually radial or CTO? Radial or femoral approach? Is it comfortable?
no, that just 1 second, please.
Yes, sure.
No, that's a great question. I tend to go bifemoral or radial femoral. I'm kind of old school in that aspect, and it's probably also a reflection of the kind of cases that I get. I'm not a big fan of biradial personally. I mean, I understand slender sheets, you can go 7 French, both sides, etc. But many times, I think right femoral is something that I think is fine. So I mean, I go a lot of right radial, right femoral. I'm not opposed to biradial, but as long as the patient can keep their hand up and over, these cases are going to be hard. You got to have a lot of options. So to me personally, I like to make it as easy as possible for everything, right? I clearly understand that study after study has shown that left femoral does have a higher complication rate, but end of the day, it's access. So I think as interventional cardiologists, when you're dealing with the big boy stuff, you got to know how to handle bigger sheets, bigger guides, etc. Now, again, all CTOs are not created equal, and I'm not saying that that's a dogmatic statement, but in most instances, I go right radial, right femoral, or bifemoral.
Thank you. Another question: you're wiring. How bravely you knuckling the wire in the antegrade way? How the fellows when feel he knuckling the wire the antegrade way?
Mohsin, I love it. Mohsin, I love knuckling.
For the fellows, you're the expert. For the fellows, how they knuckling the wires to the subintimal space? To Arun,
so I mean, honestly, I'm going to preface this whole statement by saying you have to know. I mean, because you can knuckle or because that's an option, it doesn't mean you're going to get lazy. I still think, I try to stay intra-block as much as possible. However, that being said, and like in some of the cases I showed you guys, right? I mean, it's humanly impossible to do those cases in an efficient manner without knuckling. So in general, I mean, I still think I probably resonate a little bit more with the Western philosophy, probably. So I tend to knuckle when I know, let's say you have Dr. Rahman or Dr. Khan, or you've tried to wire it and you haven't. So I might spend 5 minutes, 10 minutes max trying to wire it, but I know, all right, an expert has already tried to wire this and has failed. So to me, in my mind, I'm already thinking, I'm going to knuckle. I'm going to try this briefly because something might have changed. I might get lucky, whatever, but I'm not going to waste a lot of radiation and time and effort in doing exactly what the other person did, hoping to get lucky. So I got to do something different, right? Or like in that case that I showed you where it's like 8 tortuous and I have no idea where I'm going. So we have this inherent comfort with wires because that's how we trained as interventional cardiologists. But understand that a stiff wire can go places where you don't want it to. So knuckle is going to keep it in the architecture of the vessel. So I think the APCTO algorithm sums it up really well. When you have a long course, ambiguous course, calcific course, super tortuous, a prior expert has tried and failed, extremely calcified, knuckle.
Okay, thank you, Dr. Hasan.
I have a question to Arun.
Yeah, sure.
Mohsin, I have a question.
Yes,
to
sure.
So the question to Dr. Arun is that, Dr. Arun, are you there?
Yes. Yes,
Dr. Arun.
Yep,
No,
I am.
Yes. Yeah.
You're disappearing very frequently. So
I'm listening. I'm just not on camera all the time.
Okay. So the question is that nowadays, because there is no, can you just remember any study like this, that the whole CTO segment, like whenever I'm knuckling it, extra plaque, and then coming to the true lumen, and then you are stanting it. In that case, that some septals or some sort of smaller branches you may lose while stanting. So whether that one has any clinical implication, because some registries are telling that there is no clinical implication while stanting there, it's not going to have any impact that much in the hard outcome. But how you feel that one? That because obviously you lose some septals or smaller collaterals there.
No, I think that's a very important question, and I'm not sure we have a definitive answer yet. It seems like it's okay. Now, I mean, I think it's probably a clinical call. If you think there are significant branches in that segment where you're going to be subintimal, then yeah, you probably shouldn't, right? It's the same reason why we don't do ADR when you have distal capital bifurcation, because you're going to lose a significant side branch. It's the same concept. It's the same reason why we are much more hesitant to do ADR or reverse cart for that matter, even in a vessel which has a lot of branches, such as the LED. So, I mean, the LED is obviously a special case, right? But if it's clearly a segment where you don't have significant branches, like, you know, a circ with just one OM and you don't have anything they're going to lose, or that segment of the RCA after the RV branch before the crux, that's no big branch. I mean, I don't mind losing it there, right? I mean, especially if it's A long. So I think you have to tailor that answer depending on what is the vessel you're dealing with. You know, what are the branches that take off? What's that particular anatomy like? So, I mean, I think the answer is, and how easy is it to wire it? I mean, if it's 100 millimeters, I mean, I might wish to wire it. I might not be able to wire it. So you got to kind of tailor that based on vessel, patient protoplasm, how long is the lesion, and a lot of other factors.
Thank you, sir. Dr. Khaled, Dr. Asad. Yeah.
Assalamu alaikum and very good evening to all of you. Thank you, IPDI, for the brilliant job. Actually, today's lecture was very brilliant by the two renowned interventional cardiologists and CT operators of home and abroad. And their presentation was very excellent. Actually, Dr. Saidur sir already mentioned some of the talk was beyond our capacity, beyond our antenna actually. But I want to share two important things. One is my frustration during CTO, and another is my, I should say that is the very puzzling situation during CTO. First of all, when I win the first battle to cross the proximal segment, the proximal cave, the CTO segment, as well as the distal cave, by 1.5 or 2 hours battling by crossing the wire of these lesions, but failed to cross the even 1.25 or even 0.8 millimeter balloon. It was my very frustrating situations in CTO, procedure in my lab. This is my first one. And how to overcome this scenario, I want to know from our two elegant speakers. And second one is my very puzzling situation when I deal with the CTO relations in my lab. When I try to cross the lesions and there is a big dissections, and that leads to the obliterations of the antegrade flow, and what should be the step to overcome these situations? This is my two questions to the two speakers. Thank you very much.
Dr. Kaisar Nasrullah. Most important part, wire crossing the wire, then balloon not crossing.
Yeah. Thank you, Asad, for your nice question. I'll try with my small capacity and experience. Well, you are right. When you cross the lesion with a wire after a long fight and you are end of your game, and you suddenly find out that your balloon is not crossing, it is really frustrating. So my take on this problem is, first try a shorter profile balloon, low profile balloon, especially CTO balloon, like I've said, that like Tezona, or one is from Goodman Gibman, which will enter a bit of the CTO, and which we sometimes call it granuloplasty. We just try to poke the nose of the balloon into the CTO and then inflate the balloon, and then and a bit of the CTO proximal part dilated. Then again we push the balloon and then again dilate. So inch by inch we proceed. This is the one technique. Second is you take support. Then you see if there is any in proximal segment, there is any branch or not. If branch, you wear the branch and put a balloon, 2.5 balloon in nominal pressure. This is called anchor balloon technique. And then you push the balloon on the real wire. Second wire in the side branch and anchor it with the balloon dilation, 2.5 or 2, and then try the same balloon in the situation. This second. Third is you can use Godzilla. Godzilla will give you good support. You can take the Godzilla till the proximal end of the CTO, then try the balloon down. And if all this failed, then you'll try to take the microcatheter as much as possible in the CTO, then change the wear if possible with the rotor wear, and then do rotablation. These are the 4 techniques which I have got my setup if I fail to cross with a balloon after crossing a wear. This is the answer to your first question. And second question was, can you please repeat, Asad? Second question.
If dissection occurred.
Oh, yeah.
And closing that flow, no flow, slow flow, any phenomena.
Yeah. In CTO, if there's dissection, usually don't give so much dye. Then, the flap will increase. And if there's a dissection, keep the wear there and take a second wear and try parallel wear technique. I would say you. So then you can take a parallel wear technique and go in. So when there's a dissection, big flap, try not to give much dye or forceful dye. If you have to give very slowly, small amount of dye, so that the dissection flap does not increase. And keep your wear there. Don't try to pull it out. Take a second wear, then keep that first wear as your marker, and try to cross the CTO, keeping the first wear as a marker, so that it will guide you to cross the lesion. Thank you.
Thank you very much. Actually, have any role of retrograde approach to overcome this scenario?
Yeah, please.
So, yeah, I mean, I think Dr. Khan pretty much hit the highlights. I mean, just to summarize, right? So the first thing that you do really when you have wire across, but no device will cross, right? You want to try different microcatheter. I mean, the basics are increase your backup. So, I mean, either a Guide-Fxtension catheter, anchor balloon, whatever it takes, increase backup. That's a fundamental concept. You want to do that. Second, as he said, take the lowest profile balloon that you have, whether it's a Re-Ray or a Nick Nano, whatever you got, and try and take that after you maximize backup. He did talk about inch forming and trying to get the nose in and then balloon a little bit, go in. You could do that. You could intentionally rupture the balloon. That's balloon assisted microdissection or granuloplasty. It's really safe till about, I would say 1.5 balloon. It's fine. I've never had a problem with it. I've done it multiple times. He did talk about taking a microcatheter as far as it goes, exchanging for a rotor wire, and then drilling it. That's option 4. Option 5 is to see if wires are crossed. Once you get access to laser, that's a great indication for laser. And when you have wire across, nothing else will go. Take a 0.9 laser, set it on max fluence, and go 80-80, and just keep hammering it. That works without losing wire position. The sixth thing that you can do is try and see if you can go subintimal intentionally. I think I kind of showed you guys that, but I didn't really spend too much time on it. And the problem sometimes is that going through lumen is the hardest part, and you're not able to go. So what you do is go intentionally subintimal, crush the in the subintimal space with a balloon, and then many times that changes the morphology enough, and then you're able to get gear across in the true lumen. Now, your 7th option is your subintimal, and then you can re-enter into the true lumen. You essentially circumvent this. All else fails, go retrograde. So you have a whole list of things that can happen as this happens. When things don't go across, there's an entire algorithm. So switching gears, and with regards to the second thing, if you do have a dissection, I completely agree with Dr. Khan. Do not inject antegrade. You're done. In fact, the first thing you got to do is take off the syringe antegrade, only retrograde injections. Take a second wire. You can try parallel wire. If that doesn't work, I mean, you're greatly set up for reverse car. I mean, you're greatly set up for ADR. If you're not doing that and you have a usable collateral, you have a dissection plane. Great. Come retrograde and do reverse car. So you have multiple options if you do have a dissection. We used to think dissections were bad, but I mean, one of my jokes is many times it actually helps because you can navigate the subintimal space really fast and re-enter. So I would kind of take that, so you have a lot of options, even if you do have a dissection. But the key is don't inject antegrade anymore.
Thank you.
Yeah, Mohsin, Dr. Asad,
Yes.
can I tell, just 2 days back, I have the same scenario, and I have shown in my lecture also one one thing that I have done the granuloplasty, because wire is crossing, wire has crossed so beautifully within 10 minutes, but balloon was not crossing at all. So this is a beautiful algorithm I have shown there, the from the Korean journal, that is very beautiful. That 5 minutes you will try that one, 5 minutes you will try that one, 10 minutes you will try that one. But very simple things you can do, which I have done 2 days back, because I have tried to do granuloplasty, which it was not working. Then it's better to go for another wire, taking another wire. This is one sort of like mixing of Turlino, mixing of crowbar, mixing of, there are different terminologies are there. The another wire you take there a little bit, because you know that balloon is not going, that means another wire is not going to, that there is no enough space there to put to 0.142 wire in the CTO segment. So it is the true lumen, the first wire. The secondary you are taking closer and a little bit there, and then take that small balloon or 1.255 or 1.510, and if you just balloon it up to the optimal pressure, the wear effect of the second wear, that one is cutting that segment well, and then you can cross these things. And I have been able to go for the either granuloplasty, easier process, or another taking another wear and then balloon it as much as possible. Sometimes I take two balloons, two smaller balloons in two wears, and then and subsequently I just inflate and deflate one balloon and then another balloon. It worked. It worked because your question is very practical and really, really very much important, because that happens. And that is really painful that you are not doing that one.
Thank you. Dr. Kaisar, for tools and kits, how small balloon you cath labs? It is 110 balloon, 106 or 1.2.6. How small balloon you cath labs?
Yes, we have 1.25 into 6 millimeter. So there is
which company? Which company, Dr. Kaisar?
About the 1.26.
No, I know that Sapphire is 1.255. We have Sapphire is 1.255, 1.25 into 5, and about is 1 into 1.2 into 6.
1.2.
Yeah, we have got both of them. The about one also, and also I think it's from Teramo balloon. I forgot its name.
Yes,
it is 1.25 into 6, and we have got also 1 into 10 balloon, 1 millimeter 10 balloon.
That one is
it
from
was
Japan.
an Italian company. Now it's taken by Medtronic. 1 into 10 balloon. There is one. Yeah.
1.25.
But my practical thing is, what I feel, I don't know whether Dr. Kaisar or Dr. feels that one or not. Dr. Kaisar is with his Stingray or crossbar, so I'm not going to ask him. The 1.26, that one, has the delivery system is bigger, is not that much good, but 1.255 is beautiful.
Sure.
Sure. My choice is always 1.25 into 6 or 10.
1.26 not delivery is not good.
Yeah.
So Teramo one is very slippery, and hydrophilic coating is there over the balloon.
Sometimes sometimes I use some contrast in the balloon and then I push it, because it makes it lubricating, and then if you can lubricate it well, and sometimes it works.
Why do you put
Guys, do you have Retrograde, Sapphire Pro, and
why do you put the contrast over the balloon?
Yeah. Just like welling the body.
So how do you take to that place?
No. I pull the balloon and then wire and just make it too much here, because it when it's going through the blood and mixing it. But sometimes when you are in a desperate situation, you do everything.
Dr. Arun Sajal.
Sir.
Yes.
Thank you, sir. Thank you, Arun sir. Thank you, Kaisar sir, for excellent and extreme discussion. What I feel, the learning during our learning curve, there is the main obstacles to the time. We see our unit chiefs bring 10 to 15 cases in a cath lab and says, oh, it's taking more time. Send this patient to post-cath. So no need to proceed as a CTO case, or bring him in another day. But then another day never comes. I think this is the main obstacles for the mid-level operators like me. Yes. What I feel, when a operator tends to create himself fit for CTO operator, he should be a monk. He or she should be a monk, because he has to put his eyes on the tip of the wire and the lumbricals and the sensors of the fingers should be put in the tip of the wires. Only in that case he or she could be a CTO operator. And another thing is there are so many issues in CTO approach. So it should be treating like a pilot. A pilot is flying a plane in a stormy weather. At first he should be a good observer and good assist of a CTO operator. So what I feel, if I want to prepare myself a CTO operator, so I have to work with a CTO operator who is authentic and knowledgeable and get interest in CTO. So basically, I missed this situation. I always want to work with operator who likes to work with CTO machineries. So I feel the mid-level operators request Kaisar sir, Said Rahman sir, and Wadud sir, those who are. It's not possible only by reading books or attending this session. We need some live works. So I think
Dr.
there
Arif,
should be a proposal from you, sir.
Yeah, Dr. Arif, just what you will have to do to be a CTO operator. Just the month, the next month is that the hot Chaitro Mash. So at that time, at least 1 hour under the sun, you will have to stand without moving. So you will
exactly.
how you have perseverance, because that perseverance is very much, because 1 hour you have to 1.5 hours you have to stand in the cath lab without moving.
Yes,
and that one is really very much important.
Only one or two cases in the cath labs, and stop the OPD, then you success the CTO.
Yes.
So sometimes take 4 hours.
Thank you, everybody. Dr. Wadud sir, nice discussion, a nice topics.
Thank you, sir.
Thanks everybody. We are passing lots of time. Thanks, Dr. Arun Kalyanasundaram. Thanks you. We are grateful to IPDI being with us a long time, 2 sessions. In near future, we will come with us with live session. Dr. Arun,
exactly, sir. What are we waiting for?
Dr. Arun, last comment for you, for the fellows, and for us.
No, from the bottom of my heart, thanks a lot for having involved me. I mean, I think it's really nice to work with, or rather virtually, to kind of interact with all of you here. It's truly an honor. I hope to see everyone in person. I think we all learn from each other, and it's a continual learning process for all of us. Thanks again for the opportunity.
Yeah, I just Mohsin, I have a request to Arun. Yes. Whenever the flight is open, please come with your all adversaries, like the Stingray, Crossbows, these sort of things. In my hospital, you are invited, or any other hospital, because I need you to see doing some works in front of us, and really it is very much important.
Exactly.
Sure.
Would be honored to. Thank you.
To Kaisar, your last comment for the fellows, for the CTO, as Dr. Arif said, all the seniors for more adjusted to the cath labs. How the junior build in the cath lab CTO? Dr. Kaisar.
First, thanks from bottom of my heart to the IPDI, especially Wadud Bhai and Mohsin again, for arranging such a nice platform. We can exchange our views and transmit our experience and knowledge and legacy to our juniors to make a better Bangladesh in future. And special thanks to Dr. Arun, who is a marvelous operator. I've seen him working live in many sessions, and I'm a big fan of him. I learned a lot from him. About the juniors, I will say anybody is welcome in my cath lab for CTO. You just connect with my specialist, and when there's CTO case, you're welcome to see it. Anybody, anytime. Secondly, what the Arif told a mid-level operator about his frustration about CTOs. I say you, when I started doing CTO, then I was also like you. The beginning is always tough. So try to take some time when his cath lab is empty, like take at least 2 years in your hand and try to do CTO with one of your good friend who is also an interventional cardiologist. Sometimes it takes time, and one day my colleague did a wonderful joke with me. I always put a Foley's catheter into my CTO cases, And sometimes it happens in the beginning, I have to take 4 hours to pass a retrograde CTO. Then he said that also put a Foley's catheter to the patient and also to Dr. Kaisar as well, because he needs to pee sometimes. So what I'm trying to say, you have to have patience. You have to have patience, and please accept your failure. The failure will give you, don't get frustrated. When you fail, review the case, send it to an expert operator and go and see how he did it differently. And that failure will teach you to do in a better way next time. I can share my experience. I failed 2 or 3 cases like this, and I call it a day and bring back my patient in after 1 month or 2 months, because when there's a dissections, it needs time to heal. So you should try within 6 weeks, 1.5 months. Then some of the cases,